Hello students, so now let's start with antimicrobials, and in this section first we will start with cell wall synthesis inhibitor. So in overview, first we will classify all the antimicrobial drugs we have, and then we will in deeply discuss cell wall synthesis inhibitor, in which we will discuss one group, beta-lactam group, and we will be discussing penicillins in great detail. After that, we will also discuss about one important infection, that is MRSA. So first point is, what is antimicrobial? Antimicrobial means any drug that will kill a microbe. Now this microbe could be a bacteria, it can be a virus, it can be a protozoa, a fungi or helminthic infection. But there is a difference between two words, antimicrobial and antibiotic. Remember, antimicrobials can be natural, they are obtained from nature, or they can be synthetic. But what do you mean by the word antibiotic? Antibiotics are only natural antimicrobials. So these antimicrobials, which are antibiotics, they are obtained from bacteria. So these chemicals obtained from bacteria used to kill a microbe is antibiotic. So can we say that all antibiotics are antimicrobial because all are natural? But all antimicrobials are not antibiotic because some will be synthetic as well. So let's see what is the structure of a microbe, or let's say bacteria. Remember, bacteria, it first contains an outer cell wall. And this cell wall of a bacteria is made up of peptidoglycan. Then inside the cell wall, the bacteria contains cell membrane, and cell membrane is made up of lipid molecules like sterols. And lastly, bacteria has DNA, which is also known as nucleic acid, which synthesize proteins, and certain proteins, they work as enzymes and they help in formation of folic acid, because folic acid is required for bacterial cell division. So these are the 5 targets on which antimicrobial will act. So the first class of antimicrobial will be cell wall inhibitors. Second class of drug will be cell membrane inhibitors. Third will be DNA or nucleic acid inhibitors. Fourth will be protein synthesis inhibitors. And last group of antimicrobial which we are going to discuss will be folic acid inhibitors or antifolate drug. So this will be the broad 5 classification which we are going to discuss in whole chapter of antimicrobial. So let's start in this section with cell wall synthesis inhibitor. So which drugs are cell wall synthesis inhibitor? We can make a mnemonic. The mnemonic is BBC getting famous. So first B is a very important group, that is beta-lactam group of antibiotic. And in this beta-lactam group of antibiotic, we have 4 groups of antibiotics, that is PCCM, penicillins, cephalosporins, carbapenems and monobactam. So these 4 groups of antibiotic, they comprise a beta-lactam group. Then we have next drug bacitracin, C for cycloserine, G for again one group known as glycopeptide group. And in this group, glycopeptide group, we will discuss a very important drug, that is vancomycin, and last F stands for fosfomycin. Now we know that these drugs, they inhibit cell wall of a bacteria, and we also know that cell wall of a bacteria is made up of peptidoglycan. Now what does this word means? It means it will contain some peptides, and between peptides, it will have some glycans or sugary molecule. Sugars are in between peptides. So remember one very important point, that beta-lactam group of antibiotics, they inhibit one enzyme in a bacteria. The enzyme name is transpeptidase. So can we say penicillin, cephalosporin, carbapenems and monobactam, they inhibit linking of peptide, hence they inhibit cell wall synthesis. Another group which you have to remember for your MCQ is glycopeptide group. And in glycopeptide group, we have vancomycin. So this will inhibit the other part of peptidoglycan. Can we say the other part is glycan part? So vancomycin inhibit an enzyme trans-glycosylase, which will inhibit the attachment of glycans. So what about all other drugs? For that, let's understand that how cell wall is synthesized in a bacteria. So we know that cell wall in a bacteria is peptidoglycan. And what are peptides? Peptides are nothing. They are connection or linking of amino acid. So let's say this is a peptidoglycan cell wall in green. So these green molecules are amino acids. And the amino acid which makes this peptide is D-alanine. So it contains D-alanine amino acid. So this is first D-alanine, this is second D-alanine, third D-alanine, fourth D-alanine. And these D-alanine molecules, they are linked together with which bond? They are linked together with peptide bond. And can we say this peptide bond will be produced by which enzyme? Yes, sir. It will be produced by transpeptidase enzyme, which will link D-alanine among together. Now, between these peptides, we have sugars, and the sugars we can call it as glycans, G for glycans. Hence, this is now peptidoglycan cell wall. So, these glycans, can we say, they produce cross-linking of these amino acid? And to cross-link this amino acid with the help of glycans, which enzyme is required? Sir, trans-glycosylase enzyme is required, which attaches glycans. Now let's see how it forms. First of all, inside the bacteria, there is an amino acid known as L-alanine. This L-alanine must be converted into D-alanine. So it must be converted into some other enantiomer. So two enantiomers are known as racemic mixture. So the enzyme which is required in first step is alanine racemase enzyme. Racemase will convert L form into D form. Now this D-alanine, it gets attached with one glycan. The name of this glycan is NAM. NAM stands for N-acetyl-muramic acid. But this N-acetyl-muramic acid, it is produced from NAG. NAG stands for N-acetyl-glucosamine, which you will learn in microbiology. But in pharma, just remember to convert NAG into NAM. One enzyme is required known as enol pyruvate transferase enzyme, or in short form, APT enzyme. Now, can we say after it has been formed, this alanine, it attaches with NAM. So the enzyme required is alanine ligase enzyme, which will ligate with NAM. And the third step we have discussed, NAM gets produced from NAG. Now, after this D-alanine and NAM, they link together. These molecule of alanine and NAM, they are transferred into a forming peptidoglycan cell wall. And the molecule which transfers this D-alanine and NAM to the forming cell wall is bactrophenol. Bactrophenol is a transporting molecule. But to work, bactrophenol must be removed from phosphate. Phosphate must be removed. Only then this bactrophenol will transfer this peptidoglycan to the forming cell wall. So here we require an enzyme known as bactrophenol dephosphorylase. So we have to remove phosphate. So let's name this enzyme dephosphorylase. And now these D-alanine and NAM, which is a glycan, they will go and make a beautiful cell wall. So if we have understood this story, Let's see which drugs act on this pathway. So the first class of drug we have is the drug that will inhibit alanine racemase and alanine ligase. The name of the drug is cycloserine. Cycloserine inhibit alanine racemase and ligase. Then we have a drug which will inhibit enol pyruvate transferase. So the name of the drug is phosphomycin antibiotic. Then we have a drug which will inhibit bactrophenol dephosphorylase enzyme. So that drug also starts from the word B, which stands for bacitracin. So bacitracin inhibit bactrophenol dephosphorylase, and we already know which drug inhibit transpeptidase enzyme. Yes, that is beta-lactam group of antibiotics which contain penicillin, cephalosporin, carbapenem, and monobactam. They all inhibit transpeptidase. And lastly, we have a drug that will inhibit transglycosylase enzyme. The drug name is vancomycin. So this is to make your concept stronger. So let's come back to previous slide and write their mechanism of action. So can we say that bacitracin, it inhibits which enzyme? It inhibits bactrophenol dephosphorylase enzyme. Then we have cycloserine. Cycloserine inhibit alanine racemase and alanine ligase enzyme. And lastly, we have phosphomycin. Phosphomycin inhibit enol pyruvate transferase enzyme. Now, in this complete list, you just have to remember two names for your exam. The first is transpeptidase inhibited by beta-lactam group of antibiotic and transglycosylase inhibited by vancomycin. Other things, other enzymes are just to make you understand. So keeping this thing in mind, one question comes very commonly. Any drug which is a cell wall synthesis inhibitor, BBC getting famous, all these drugs are not effective in cases of infection due to atypical bacteria. Atypical bacteria like Mycoplasma, Chlamydia, Rickettsia. Against them, penicillin, cephalosporin, vancomycin. Question is asked, why they are not effective? The reason is very simple. These atypical bacteria like Mycoplasma, they lack cell wall. These bacteria, they don't have cell wall. That is why penicillins, vancomycin is not effective against these infection. So keeping this thing in mind, in this section, let's learn about beta-lactam group of antibiotic first, in which we will discuss penicillins. So let's start with beta-lactam group of antibiotic. So beta-lactam group of antibiotic contains 4 antimicrobials, that is PCCM, penicillin, cephalosporin, carbapenems and monobactam. Now why they are known as beta-lactam group of antibiotic? Because all these drugs, they contain a common beta-lactam ring. They contain a common beta-lactam ring. Now how to draw a beta-lactam ring? Let's make a square. And in this square, we will write 3 carbons and 1 nitrogen. Make a square with 3 carbon and 1 nitrogen. And in 1 carbon, attach oxygen. So this ring is beta-lactam ring. And this beta-lactam ring is the ring that will kill a bacteria. It will kill a bacteria. Sir, how it will kill a bacteria? We know that this beta-lactam ring will inhibit which enzyme? It will inhibit transpeptidase enzyme. And by inhibiting transpeptidase enzyme, it will kill a bacteria. Remember, all these drugs are bactericidal drugs. All these drugs are bactericidal drugs. They cause complete killing. They are very effective drugs we have. So let's understand one part, that what is the difference between these 4 drugs. So let's understand again with this beta-lactam ring. Can we say all these 4 drugs, they contain a common beta-lactam ring? And this common beta-lactam ring is responsible for killing of a bacteria by inhibiting transpeptidase enzyme. But these four beta-lactam group of antibiotic, how they are different from each other? How they are different? They contain one more side ring. And this side ring can be different, and depending upon the difference in side ring, it can be penicillin. Penicillin will have some different side ring. Second will be cephalosporin. It will have some different side ring. And third we have carbapenems. So carbapenems will have some different side ring. Now one question comes very commonly. Sir, which beta-lactam group of antibiotic does not contain side ring? So see the fourth name which we have written, monobactam. Fourth drug was monobactam. From this name we can identify mono means it only contains B for beta-lactam ring. It means monobactam has no side ring. So it does not have any side ring. That is why it is known as monobactam. And in this monobactam group of antibiotic, we have one drug. Only one drug is there. The drug name is aztreonam. So which drug is there? Aztreonam. So what is the importance of this side ring now? Now this side ring, it is responsible for one side effect of these drugs. The main side effect of penicillin, cephalosporin and carbapenem is hypersensitivity. It leads to hypersensitivity, or we can write allergic reactions. Not just allergic reaction, we will write that these three group of antibiotic, they can also produce cross allergy. Cross allergy means, let's say if a patient is allergic to penicillin, in that patient, remember, even the other two drugs like cephalosporin and carbapenems, they can also cause allergy. Cross allergy means if a patient is allergic to penicillin, even carbapenem and cephalosporins are contraindicated in a patient of penicillin allergy. The reason you will write is cross allergy. So never give cephalosporin or carbapenem if a patient is allergic to penicillin. And here comes a question. Can you tell me which beta-lactam is the only drug which can be given in penicillin, cephalosporin and carbapenem allergic cases? So monobactam is the drug because it shows no cross allergy. Why no cross allergy? The reason we already know, it does not contain side ring, hence no cross allergy. That is why monobactam can be safely given if a patient is allergic to penicillin, cephalosporin and carbapenem. So keeping this thing in mind, let's start with the first group of beta-lactam group of antibiotic, penicillins. So let's make a heading, penicillin. Now in penicillin group, remember any drug which I will be telling you will be ending with the word cillin. If I say penicillin, amoxicillin, piperacillin, dicloxacillin, cillin word will always come. Now in this penicillin group, the first drug which we made was penicillin G. And this penicillin G, it was made around the time of World War II. So during World War II, there was a scientist known as Alexander Fleming and his students Chain and Flory, who made this penicillin G. And this penicillin G, it saved millions of lives, because at that time many people were dying in wars, in jails because of infection. So it saved lot of millions of lives. So let's respect this penicillin. Let's call it as penicillin G. G means we are giving respect to it. So this penicillin G, it has two more names. It is also known as benzyl penicillin. Another name of penicillin G is benzyl penicillin. It is also known as crystalline penicillin. Now the important point with penicillin G is that it was the first drug to be made in penicillin group, and it is the only natural penicillin we have. It is the only natural penicillin. Rest all other penicillins are synthetic drug. So this penicillin G, at that time, it was discovered from a fungus. The fungus name we all know is Penicillium notatum. And the scientist, we must thank to this scientist who discovered this penicillin from Penicillium notatum was Sir Alexander Fleming. But later on, this penicillin was commercially prepared on large scale. It was commercially prepared on large scale from some other species of penicillium, that is Penicillium chrysogenum. So commercially chrysogenum. And the students of Alexander Fleming like Chain and Florey, they were responsible for commercially preparing this penicillin on large scale. And later on is the history we all know. Alexander Fleming, Chain and Florey, so they received Nobel Prize for this penicillin G. Now penicillin G, how it is given? It is only given by injections. And in injection, it is given intravenously. Now, penicillin G, it is a highly polar molecule. Polar means it is a highly water-soluble molecule. So, do you think a water-soluble drug can easily cross cell membrane? The answer is no. That is why penicillin G has a very poor brain penetration. But it has a very poor brain penetration still. Remember, still penicillin G, it is given for the treatment of meningitis. It is still given in the treatment of meningitis. Why? Because, sir, in meningitis, this blood-brain barrier, it becomes damaged. So because blood-brain barrier becomes damaged in meningitis, this penicillin, which was earlier not able to enter into the brain, but they can enter in cases of meningitis. And lastly, it has a very poor eye penetration and it has a very poor prostate penetration. So just write for an MCQ. So here comes a question, where do we use penicillin G? Penicillin G, it is the drug of choice. We can make a mnemonic, smart player Gale. Gale is a cricketer of West Indies. So, SMART stand for first use of penicillin G is syphilis. And it is the drug of choice for neurosyphilis. And we are going to discuss the treatment of syphilis in this section. It is also given for meningococcal meningitis. But we will make a star out here. Star means recently the treatment of meningococcal meningitis has been changed. So now penicillin G is no longer the drug of choice. It is still the drug of choice for actinomycosis. Penicillin G is also the drug of choice for rat bite fever. Rat bite fever is caused by bacteria like Streptobacillus and spirylosis. It is sometimes also known as Sudoku fever. Penicillin G is the drug of choice for tetanus, and how we can remember? Tetanus, penicillin G was made at the time of World War. In World War, there were wounds during war. In wounds, there is tetanus infection, and penicillin G saved millions of lives. It is also the drug of choice for Pasteurella multocida. Penicillin G is also the drug of choice for gas gangrene. Very commonly asked question. Gas gangrene is caused by Clostridium perfringens. Again, just like tetanus, during war, this bacteria is found in soil. It can enter into the blood and it can cause severe damage of muscles. This gas gangrene is also known as myonecrosis. And the drug of choice for gas gangrene, again, penicillin G, who saved millions of lives during World War. Penicillin G is also the drug of choice for anthrax. Yaws is caused by Treponema pertinue. It is also the drug of choice for leptospirosis. So in leptospirosis, we give penicillin G along with the drug doxycycline. And lastly, very important point, penicillin G is the drug of choice for every species of Staphylococcus and Streptococcus. If sensitive, why we are writing a word if sensitive? Because at today's time, Staphylococcus and Streptococcus, they have acquired resistance against penicillin G. So if it is sensitive, yes, you can give penicillin G, but nowadays widespread resistance is there. Sir, why it has happened and how it has happened, we will be discussing in this section. So this penicillin G, what is the main side effect? So let's talk about one infection which has been changed, that is meningococcal meningitis. So treatment of meningococcal meningitis, remember meningococcal meningitis is caused by 1 gram-negative bacteria, that is Neisseria meningitidis. So this bacteria causes. Now remember, this bacteria spreads in community and it is a gram-negative bacteria. I will tell you later on. Any gram-negative bacteria which spreads in community like Neisseria meningitidis, Neisseria gonorrhea, similarly typhoid caused by Salmonella, any gram-negative infection which spreads in community, always the drug of choice is injections of ceftriaxone. So ceftriaxone now is a better drug than penicillin G. So it is a better drug than penicillin G. But remember, we have to give drug for prophylaxis also. Why, sir? So just imagine one case of meningococcal meningitis came to you in hospital. Don't you think from those patients, it can spread to close contact also, like family members, healthcare professional? Why? Because this meningococcal meningitis bacteria, from that patient, it can come to healthy individual and it first comes into nose. From nose, it remains as a carrier state and then it spreads to the body. So in close contact of meningococcal patient, we have to give drugs for prevention. So prevention or prophylaxis is given in close contacts. And why we give in close contact? To eliminate nasal carrier state, because this bacteria comes and harbors into nose. Now here we prefer to give an oral drug, and the overall drug of choice for prevention or prophylaxis of meningococcal meningitis is ciprofloxacin. It is the drug of choice. But yes, we can give one TB drug also. This drug is also given in TB. Rifampicin can also be given, but rifampicin is less effective. Overall drug of choice is ciprofloxacin. But remember one rule, that this ciprofloxacin, it is contraindicated in pregnancy, and ciprofloxacin is also contraindicated in children. So question comes, which drug we give for prophylaxis of meningococci in pregnant females and children? Again, we will give injections like intramuscular injections of ceftriaxone. So ceftriaxone can be given for prevention in cases of pregnancy and children. So this is the treatment of meningococcal meningitis. Now let's talk about penicillin hypersensitivity. The main side effect of penicillin is hypersensitivity. So it is seen in 4 to 5% of people. That means if I give penicillin in 100 people, 4 or 5 people, they suffer from allergy. And what was the cause of allergy? Is it beta-lactam ring or side ring? Yes, the cause of allergy is side ring. And the side ring in penicillin is 6-amino-penicillinoic acid. 6-amino-penicillinoic acid. So that is why as a doctor, it is always mandatory that before giving penicillin injection, we must do allergenic testing. We must do allergic testing in our patient. So what we do, we use this molecule only and we give intradermal injection and we see whether the person is allergic or not. Now the question is, which type of hypersensitivity penicillin can cause? Remember, there are 4 types of hypersensitivity, and penicillin, it can cause all 4 types of hypersensitivity. So let's write their name. Type 1 hypersensitivity, type 2, type 3, type 4. Remember, type 1 is immediate type of hypersensitivity. So the patient can suddenly go into shock and patient may die. That means in type 1 hypersensitivity, there is anaphylaxis, but mild allergy can also happen like rashes, urticaria. Now, type 2 hypersensitivity, which is antibody-mediated hypersensitivity, these antibodies, they kill RBC because penicillin is attached on the surface of RBC, so it can lead to hemolytic anemia. And how we detect these antibodies which mediate type 2 hypersensitivity? We do a test to detect this antibody known as Coombs test. So Coombs test will be positive in type 2 hypersensitivity if there is hemolytic anemia. In type 3, it can cause immune complex mediated, which is also known as serum sickness. And type 4, which comes very late, it can also cause delayed type of hypersensitivity as well. So here comes a very important question. Sir, what is the drug of choice for penicillin allergy? The overall drug of choice for penicillin allergy is macrolides, macrolide group of antibiotic. So among macrolide group of antibiotic, we have drugs like erythromycin, azithromycin. So they are the drug of choice in penicillin allergy. How we can remember this? So you know that you suffer from sore throat, we eat penicillin-like drug like amoxicillin, but it sometimes becomes very costly. So when we have sore throat, either we take penicillin group of drug or we take azithromycin. Because they have same spectrum of action, they say they kill same bacteria, but they can be given in penicillin allergic or penicillin hypersensitivity individual. Any other drug which we can give? Yes, we can also give clindamycin. Clindamycin can also be given in penicillin hypersensitivity as well. So now let's talk about what were the drawbacks of penicillin G and how we overcame those drawbacks. Remember, we will discuss 4 drawbacks of penicillin G. And to overcome these 4 drawbacks of penicillin G, now we made new synthetic penicillins. So we made new synthetic penicillin. So the first drawback of penicillin G was that penicillin G was acid labile. Acid labile means when you give orally, the acid present in the stomach degrades, it becomes degraded in stomach. That is why penicillin G we cannot give orally. To overcome this drawback, we made acid stable penicillins. We made acid stable penicillin and we will discuss they are given orally. The second drawback of penicillin G was that penicillin G was very short acting drug. Now to overcome this drawback, we made long acting penicillins. Third drawback was that penicillin G was very narrow spectrum. It cannot kill a very big family, that is Enterobacteriaceae family. Now to overcome this drawback, we made extended spectrum penicillin. We extended the spectrum and we will discuss they will also kill Enterobacteriaceae family as well. And the last drawback is with the time, now many bacteria have started acquiring resistance against penicillin G. Now to overcome those resistance, we did 2 things. First, we made penicillinase resistant penicillin and we made beta-lactamase inhibitors. So what are all these points? Let's discuss each of these new penicillin one by one. So first, let's start with acid labile, acid stable. So what do you mean by acid labile? Penicillin G was acid labile. In simple word, when we gave this penicillin G orally, this penicillin G came to stomach, and in stomach, we all know we have HCl or acid. Acid is present in stomach. Now this HCl in stomach, remember, degrades penicillin. It degrades penicillin. So penicillin G, it is degraded by acid, that is HCl in stomach. That is why penicillin G is not given by oral route, it is given by injection. Now to overcome this drawback, we made acid stable penicillin. And can we say acid stable penicillins, they are not degraded by HCl in stomach. Because of this reason, only these penicillins will be given orally. Okay, they are oral penicillin. So how to remember their name? Remember a mnemonic, vodka. So V stands for penicillin V. V for penicillin V. O for oxacillin. D for dicloxacillin. C for cloxacillin. A for ampicillin. And next a very famous drug, amoxicillin. So remember, these penicillins are given orally. Now one additional point, remember another name of penicillin V is phenoxymethyl penicillin. It is also known as phenoxymethyl penicillin. And another name of dicloxacillin is, it is also known as flucloxacillin. So these are another name. Now these penicillins are given orally. Now except amoxicillin, just encircle all penicillins except amoxicillin. That is penicillin V, oxa, dicloxa, cloxa and ampicillin. Remember these penicillins, their absorption when given orally, their absorption is reduced by food. Food reduces absorption, and antacids, which reduces or neutralize HCl in the stomach. These drugs and this food reduce the absorption of this penicillin. So tell me, would you like to give this penicillin with food or without food? Yes. So these penicillins, remember, they should be given empty stomach. They should be given empty stomach. That means they must be given at least 30 minutes before meals and after taking penicillin for next 2 hours. Do not eat anything. So stomach should be empty. But exception to this rule is amoxicillin. So amoxicillin, remember, food does not reduce absorption of amoxicillin. Because of this reason, amoxicillin can be safely given with food as well. So that is why it is a very famous drug as well. So now let's talk about second drawback of penicillin G. Penicillin G was very short-acting drug. Sir, why? Because when we give penicillin G, this penicillin G goes to the kidney. It gets rapidly excreted out in urine. So can we say it will no longer remain in the body? That is why it is very short-acting. Now in kidney, there is a transporter which excretes this penicillin into the urine. The name of this transporter is OATP transporter. So this concept we have discussed in general pharma also, organic anion transporter protein. So because of this reason, remember this penicillin G, it is rapidly excreted in urine by OATP transporter. That is why it is short acting. Now to overcome this drawback, we made long-acting penicillin. So the first long-acting penicillin is, with this penicillin G, we combine one drug, probenecid. And why we combine probenecid? Because probenecid inhibit the transporter OATP transporter. So it inhibits OATP transporter probenecid. So can we say probenecid inhibits the excretion of penicillin in urine? So that is why, because it is inhibiting penicillin excretion in urine, why we are combining probenecid? It is combined with penicillin to make penicillin G longer acting. It is combined with penicillin longer acting. Now this combination, remember, of penicillin G and probenecid, it is given intravenously. Now we have two more penicillin. Now with this penicillin G, we attach one group known as procaine group, or we attach one group benzathine group. When we attach procaine and benzathine, these procaine and benzathine, they make this penicillin G longer acting. And these two penicillin, remember, they are given by intramuscular depot injection. Now, intramuscular depot injection, it is also known as repository injection. Now, what does it mean? Remember, when we give procaine or benzathine penicillin in muscle, it remained deposited in muscle. So, depot injection, and very slowly, it will come into the blood. That is why they will become very long-acting drug. But remember, they are given intramuscularly. Never give these drugs IV. We never give IV. Why? Because if you give intravenously, this procaine, when given IV, it is highly neurotoxic molecule. This benzathine, it is highly cardiotoxic molecule. It damages heart. So never give procaine penicillin and benzathine penicillin IV. They are only given intramuscularly. Now one question comes, sir, overall, which is the longest acting penicillin? The which is having longest name? Yes, that is benzathine penicillin is the overall longest acting penicillin. Longest penicillin is benzathine penicillin. So don't you think if it is such a long acting drug, can we give benzathine penicillin for prevention of a disease also? Because for prevention, we don't want to give repetitive dose of a drug. So because of this reason, let's talk about the uses of benzathine penicillin. Benzathine penicillin, it is the drug of choice for prevention or prophylaxis of rheumatic fever. So we all know that rheumatic fever is caused by group A streptococci bacteria. And for prevention, we give a long-acting drug, benzathine penicillin. So how we give? Remember, benzathine penicillin, it is given intramuscularly. And the dose is, 1.2 million international unit in children who are more than 20 kg of weight. But if the weight is less than 20 kg, we reduce the dose by half, 0.6 million international unit. And this benzathine penicillin, remember, it is given once a month for prevention of rheumatic fever. So once a month, such a long-acting drug. And another use of benzathine penicillin is, benzathine penicillin, it is the drug of choice for syphilis. So the overall drug of choice for syphilis is benzathine penicillin. And we will write a very important statement that benzathine penicillin, it is the drug of choice for all stages of syphilis. It is the drug of choice for all stages of syphilis except one stage, except neurosyphilis. In neurosyphilis, benzathine penicillin is not effective. So where it is not used? Neurosyphilis. The reason is benzathine penicillin, it has a very poor brain entry. So that is why it is not given in neurosyphilis. So keeping this thing in mind, let's talk about the treatment of syphilis now. So syphilis, it is caused by Treponema pallidum. Now syphilis is a sexually transmitted disease. So just imagine a patient came to you and the patient is having genital ulcer. That genital ulcer in syphilis is known as chancre. So when a patient is having genital ulcer, let's call this stage as primary syphilis. Now from this ulcer, this syphilis comes into the blood and spreads everywhere. So when it comes into the blood, this is known as secondary syphilis. Now from the blood, it will go and deposit in organs. And in organs, it will sleep. It will become dormant. If it will sleep or remain dormant for less than 1 year, we call it as early latent syphilis. Latent means dormant stage. But if this syphilis remains dormant for more than 1 year, we call it as late latent syphilis. Now this syphilis will wake up. It will again wake up. It will come out of the organ. And when it is coming out of the organ, it damages those organs. When organ become damaged, then it is known as tertiary syphilis. So if heart and aorta becomes damaged, this is known as cardiosyphilis, cardiovascular syphilis. So it's a type of tertiary syphilis. And if brain becomes damaged, we call it as neurosyphilis. So let's see what is the treatment, what is the drug of choice. Remember, the drug of choice for primary, secondary and latent syphilis, early latent syphilis is benzathine penicillin. Sir, what is the dose? Dose is 2.4 million international unit. How we give? Intramuscularly, only one injection. Only one injection will treat the first 3 stages of syphilis. But if it is late latent, tertiary and cardiovascular syphilis, again the drug of choice is benzathine penicillin. But in this case, we give 2.4 million international units. Intramuscularly, we give 3 injection. How we give 3 injection? Remember, once per week. We give 1 injection per week for 3 weeks. So total how many injection we will give? 1 injection in 1 week and total treatment will go for 3 weeks. So can you tell me what is the total dose of benzathine penicillin we give in late latent tertiary and cardiovascular syphilis? That is 2.4, 2.4, 2.4. The total dose will become 7.2 million international units. So we have to give 3 injections. Now, what about neurosyphilis? We discussed that in neurosyphilis, benzathine penicillin is not effective. In neurosyphilis, the drug of choice is aqueous penicillin. So aqueous penicillins are the remaining 2 penicillins which we have discussed. That is penicillin G with probenecid, or it is procaine penicillin. The remaining 2 penicillins are known as aqueous penicillin. So they are the drug of choice for neurosyphilis. Now remember, penicillin causes allergic reaction. And it causes a very dangerous allergic reaction in syphilis, that is Zarisch-Herxheimer reaction. So penicillin in syphilis can cause one hypersensitivity, that is Zarisch-Herxheimer reaction. So if a patient is having syphilis with penicillin allergy, then what to do? Then the drug of choice is doxycycline. Doxycycline. If doxycycline is not given in the option, then you can go with erythromycin. So penicillin, allergic in syphilis patient, give doxycycline. Now what about syphilis in pregnancy? Syphilis in pregnancy, again the drug of choice is penicillins. Those respective penicillins which we have written, either benzathine penicillin or aqueous penicillin, depending upon the stage. But just imagine that this pregnant female is allergic to penicillin. So it is allergic to penicillin. Can we give penicillin? No. But the point is, if she is allergic, even doxycycline is contraindicated. Doxycycline is contraindicated in pregnancy. So sir, what to do now? So remember, syphilis in pregnancy, and if the mother is allergic to penicillin, in that case do penicillin desensitization. We do penicillin desensitization. If a pregnant female is allergic to penicillin, we can't give doxycycline also. So we give very low dose of penicillin and we make her desensitize. So sir, what is this Zarisch-Herxheimer reaction? So Zarisch-Herxheimer reaction is penicillin hypersensitivity in syphilis. Now which type of hypersensitivity it is? Remember, it is type 3 hypersensitivity. Now what is type 3? Let's understand. Just imagine this is syphilis. A patient is suffering from syphilis. Now you have given penicillin. Can we say penicillin, it will kill syphilis bacteria? And when syphilis bacteria gets killed, remember the antigens of this syphilis, they come into blood. Agreed? Now when these antigens, they will come into the blood, against this antigens, remember, antibodies are produced. So can we say now this antigen-antibody complex, which is known as immune complex, it will circulate in the body. It is circulate in the body and it will deposit in various organs, especially skin, and skin will become damaged. There will be lot of rashes. So can we say this is immune complex mediated hypersensitivity? Type 3 hypersensitivity is immune complex mediated. So now what is the treatment? The management of Zarig-Shirk-Seymour reaction is do not stop penicillin. So if the patient comes to you with Zarig-Shirk-Seymour reaction, do not stop penicillin. Just start the patient on corticosteroids. Just add corticosteroids. Because corticosteroid, they reduce inflammation, they reduce this hypersensitivity. So after this Zarig-Shirk-Seymour reaction, let's talk about the third drawback of penicillin G. So we discussed penicillin G, it was a very narrow spectrum drug. And this penicillin G, remember, it is not effective against one very big group of family of bacteria. It is not effective against Enterobacteriaceae. It is not effective against Enterobacteriaceae. Remember, this Enterobacteriaceae is a very big group of gram-negative bacteria which contains various bacteria like E. coli, Pseudomonas, Klebsiella, Salmonella, which causes typhoid, Shigella, etc. So against all this big group of Enterobacteriaceae, penicillin G is not effective. To overcome this drawback, we made extended spectrum penicillin. As the name will tell you, extended, its spectrum has been increased, and you will say, sir, this extended spectrum penicillin, it is even effective against Enterobacteriaceae family. So it is even effective against Enterobacteriaceae. So what are the different penicillins we have among extended spectrum penicillin? Let's learn. So extended spectrum penicillin, it is further divided into three groups: aminopenicillins, carboxypenicillins, and uridopenicillin. Now we don't have to remember this name, amino, carboxy, urido. What you have to remember is what all drugs of extended spectrum penicillin are present there. In aminopenicillins, we have two drugs with starting with the word A. One is ampicillin and second is amoxicillin. So can we write here as A2? In carboxypenicillin group, we have carbanicillin and ticarcillin. So let's write mnemonic CT. And lastly, we have uridopenicillin, in which we have meslocillin, azolocillin, and a very famous drug, very commonly we use in our hospital setting, that is piperacillin. So let's make a mnemonic MAP. Now let's pronounce this mnemonic again. Can we call extended spectrum penicillins are A2CT MAP? A2CT MAP you have to remember. Now the question comes, out of this extended spectrum penicillin, which can be given orally also. So recall that mnemonic, vodka mnemonic. Among them, remember ampicillin and amoxicillin, they can be given orally as well. These were oral penicillin. What about other penicillin? Other penicillins are only and only given by injection. So now question arises in our mind that against which group of bacteria, against which Enterobacteriaceae they are effective. So first is E. coli. With E. coli you will write ampicillin, amoxicillin, that is A2, it is effective. CT is also effective, carbanicillin, ticarcillin, and meslo, azlo, and piperacillin, they all are effective against E. coli. So can we say against E. coli we have A2CT MAP, all are effective. Now the next bacteria is Pseudomonas. Remember in Pseudomonas, this is a very important question, ampicillin and amoxicillin, they are not effective. Against Pseudomonas only CT MAP is effective, and piperacillin is effective against Pseudomonas. This is a very commonly asked question. So in Pseudomonas only CT MAP are effective. Now let's talk about Klebsiella. So in Klebsiella, remember, neither ampicillin amoxicillin is effective nor carbanicillin ticarcillin is effective. The only penicillin which are effective against Klebsiella are MAP. So only and only MAP are effective against Klebsiella. So can you now tell me, among them, which of the following penicillin has largest spectrum of activity, which is effective against all types of Enterobacteriaceae? Yes, that is MAP. Can we say that these MAP, meslo, eslo and piperacillin, they have the largest spectrum. That is why this piperacillin is such a famous drug we very commonly use in hospital. Not just that, this piperacillin group of drug, it is also effective against Proteus also. It is also effective against anaerobic bacteria also. So piperacillin, Proteus and anaerob, very good activity. So that is the largest spectrum. Now let's discuss about two very famous drugs in great detail. That is ampicillin and amoxicillin. Let's see what is the difference we have between ampicillin and amoxicillin. Ampicillin, it is the drug of choice for one bacteria known as Listeria. Listeria causes one infection known as meningitis. It is also the drug of choice for Enterococcal faecalis. Enterococcal faecalis can cause one very severe infection known as endocarditis. So in Listeria meningitis and Enterococcal endocarditis, we give the combination of ampicillin with one drug, gentamicin. This is the treatment of Listeria meningitis and Enterococcal endocarditis. What about amoxicillin? When you will learn ENT as a subject, ear, nose and throat infection, whole ENT ends on one drug, that is amoxicillin, because all ENT infection are most commonly seen with a bacteria known as Streptococcus pneumoniae, and amoxicillin is the drug of choice for Streptococcus pneumoniae, all ENT infection like sore throat, tonsillitis, pharyngitis, otitis media. When it enters into from larynx to lungs, it can cause community acquired pneumonia. That is why most commonly when you suffer from sore throat, you take amoxicillin. You don't take ampicillin because sore throat is mainly caused by Streptococcus pneumoniae. Drug of choice is amoxicillin. Now ampicillin, as compared to amoxicillin, it is more effective against Haemophilus influenza. So it is a gram-negative bacteria which spreads in community, while amoxicillin is more effective against Salmonella. And we know Salmonella can cause typhoid. But are they drug of choice? Sir, no. I have told you one rule. Any gram-negative infection which spreads in community like meningococci, H. influenza, typhoid, always the drug of choice is ceftriaxone. So here the drug of choice will be ceftriaxone, that is a third generation cephalosporin. Another difference is ampicillin, it has less oral bioavailability, while amoxicillin, among all penicillin, it has best oral absorption. That is why these drugs are taken orally. Now remember, ampicillin, it is more excreted in bile, while amoxicillin, it is less excreted in bile. Now what is the importance of this part? Let's understand. So can we say ampicillin, it has more excretion in bile as compared to amoxicillin? So let's see if this ampicillin is excreted through liver. This ampicillin and amoxicillin, they will come in bile into the intestine. Now don't you think in our intestine or colon, we have good bacteria? These good bacteria are also E. coli like bacteria which are good for us. And don't you think ampicillin and amoxicillin, they can kill E. coli in GIT? So when they kill this E. coli in GIT, their main side effect is diarrhea, because these good bacteria, they are responsible for absorption of food nutrient. That is why ampicillin more and less with amoxicillin, patient suffers from diarrhea because they kill GIT bacteria, they are excreted in bile. Now sometimes when this good bacteria is killed, one harmful bacteria can grow now. This harmful bacteria which can grow now, because ampicillin has killed the good bacteria, there is an overgrowth of one bacteria known as Clostridium difficile bacteria, which can lead to one disease known as pseudomembranous, and in colon there will be inflammation, pseudomembranous colitis. So if I'll ask you a question, which drug has more risk of causing pseudomembranous colitis? Is it ampicillin or amoxicillin? Sir, you will say it is more seen with ampicillin because ampicillin is more excreted into bile. Now next point is this ampicillin. It is absolutely contraindicated in one virus infection. It is contraindicated in Epstein-Barr virus infection. Because it has been seen when we give ampicillin in Epstein-Barr virus infection, it can lead to severe allergic reaction. The reason we don't know. Now what we did, we modified this ampicillin into BAC ampicillin and Piva ampicillin. These drugs are prodrugs of ampicillin. That means inside the body, they will be converted into ampicillin. And why we have made? Because these drugs have better oral absorption as compared to ampicillin. So these are the modified forms. So the last drawback of penicillin G, the fourth drawback was that certain bacteria with the time, they have acquired resistant against penicillin G. Now first bacteria is a gram-positive bacteria. Like Staphylococcus, it has acquired resistance. To overcome this resistance, we made penicillinase resistant penicillin. While in gram-negative bacteria like Enterobacteriaceae, which contains E. coli, Pseudomonas klebsiella, to overcome the resistance, we made beta-lactamase inhibitor. Now what does it mean? Let's understand this concept in great detail. So first is resistance in gram-positive bacteria, mainly Staphylococcus. Yes, it is also seen in Streptococcus. So can we say for Staphylococcus, the first drug which we made was penicillin G. This penicillin G enters into Staphylococcus and it inhibits cell wall synthesis by inhibiting transpeptidase enzyme. But this Staphylococcus, it has started producing one enzyme. And let's call this enzyme as penicillinase enzyme. So see the name penicillinase enzyme. What it will do? This penicillinase enzyme, it will degrade penicillin G. And penicillin G will not be able to kill this Staphylococcus. So can we call this Staphylococcus as penicillinase producing Staphylococcus aureus, against which penicillin G will not be effective. To kill this penicillinase producing Staphylococcus, we made penicillinase resistant penicillin. So the name is now very logical. So we made penicillinase resistant penicillin because they will not be degraded by penicillinase enzyme. So what are those penicillin? We can make a mnemonic condom. C for cloxacillin, O for oxacillin, N for nafcillin, D for dicloxacillin, and M for very famous methicillin. So these penicillins are given for penicillinase producing Staphylococcus. Now remember one point, that cloxacillin side effect is It causes C for coagulation abnormality. That means it decreases the production of clotting factors, which can increase the risk of bleeding. Oxacillin and dicloxacillin, these two drugs are hepatotoxic drugs. While N for neficillin, neficillin causes neutropenia. Last drug is methicillin. Very important. Methicillin can cause permanent damage of kidney, which is known as interstitial nephritis. Because of the risk of interstitial nephritis, methicillin now is no longer used for the treatment of staphylococcus in the patient. Next question, which of them are oral, which of them are IV? If you remember, cloxacillin, oxacillin and dicloxacillin, they were also acid-stable penicillin, vodka, so they can be given orally. So which penicillinase-resistant penicillin is the only IV drug? The only IV drug we have is neficillin. So dicloxacillin use, if somebody will ask you, you will say, sir, it is given for the treatment of resistant staphylococcus, which is producing penicillinase enzyme. But the story doesn't end here. This staphylococcus is a very notorious bacteria. It is a superbug. It has now acquired some other causes of resistance as well. So let's understand this part again. For this staphylococcus, we made penicillin G. And this penicillin G inhibits cell wall by inhibiting an enzyme known as transpeptidase enzyme in staphylococcus. But this staphylococcus started producing an enzyme, penicillinase enzyme. So can we say penicillinase enzyme producing Staph aureus? If it is producing penicillinase enzyme, this penicillinase will degrade penicillin G. To overcome this resistance in staphylococcus, we made methicillin-like drug. These were penicillinase-resistant penicillin. And the complete list we know is condom. So they were penicillinase-resistant penicillin. It means they are not degraded by penicillinase enzyme. That means they will still go and inhibit transpeptidase enzyme and they will kill this penicillinase producing Staph aureus. Can we call this Staph aureus, which is penicillinase producing Staph aureus, as MSSA? Because it is killed with methicillin, we call this Staph aureus as methicillin sensitive Staph aureus, because it is killed by methicillin. But the story doesn't end here. This Staphylococcus aureus now has acquired another type of resistance. That another type of resistance which has acquired is this transpeptidase enzyme, which is produced by Staphylococcus. There is some mutation. Because of mutation, no penicillin can bind to transpeptidase enzyme. Not even methicillin can bind to transpeptidase enzyme. Hence, this type of Staphylococcus aureus, which is not killed even by methicillin, we call it as MRSA. MRSA stands for methicillin resistant Staph aureus. So if I'll ask you a question, what is the cause of resistance in MRSA? Sir, you will say it is due to mutation in transpeptidase enzyme, and now no penicillin can act on transpeptidase enzyme. Even methicillin cannot act. So let's talk about MRSA, which is methicillin resistant Staph aureus. It is resistant to many antibiotic, and any drug which is resistant to many antibiotic is a superman, or it is known as superbug. It's a very strong bacteria. So what was the cause of resistance? The cause of resistance in MRSA is there is mutation in transpeptidase enzyme. Can we say transpeptidase enzyme, all penicillins, they bind to this enzyme and inhibit cell wall synthesis? That is why this transpeptidase enzyme, it is also known as PBP2A. PBP2A stands for penicillin binding protein, because all penicillins, they bind to this enzyme and inhibit cell wall. So this mutation, how this Staphylococcus aureus has acquired, it is because of mutation in one gene. In Staph aureus, the name of the gene is MEC2A gene. MEC2A gene mutation can lead to mutation in transpeptidase enzyme, and this gene, this bacteria has acquired from a virus. When a resistant gene is acquired from a virus, this method of resistance is known as transduction. So due to transduction or viral acquisition of gene, it has made this Staph aureus as MRSA. So here comes the question. Can we say in transpeptidase enzyme in MRSA has been mutated? But we have discussed all beta-lactams, whether it is penicillin, cephalosporin, carbapenem and monobactam, all beta-lactams, they inhibit transpeptidase enzyme. And in MRSA, this transpeptidase enzyme has been mutated. Because of this sudden mutation, all penicillin, all cephalosporin and all carbapenem, they become resistant or ineffective to MRSA. Suddenly, MRSA will become resistant to all beta group of antibiotic, because all of them inhibit transpeptidase, but there is an exception to this rule. Recently, we made a very new drug, that is 5th generation cephalosporin. 5th generation cephalosporin is the only beta-lactam which is effective against MRSA. It is effective against MRSA because this cephalosporin can bind to mutated form of transpeptidase enzyme. There is another class of drug which is resistant to MRSA, that is macrolides. Macrolides also become ineffective against MRSA, and in macrolide we already know the drugs were erythromycin and azithromycin. So macrolides are also not effective against MRSA. So here comes the question. How to kill this resistant bacteria? What are the drugs we have for MRSA? We divide these drugs for MRSA into 3 types. Intravenous drug. Don't you think intravenous drugs are given for serious infection like meningitis, septicemia? Oral drugs are given for less severe infection. Let's say it is an infection on skin and soft tissue. So oral drugs are given for skin and soft tissue infection. Plus we have a topical cream for MRSA. Topical cream is used to kill nasal state of MRSA. Because this MRSA is present in nose as well. So what intravenous drug we give for MRSA? So logically, we cannot inhibit transpeptidase enzyme because it has been mutated. So let's inhibit transglycosylase enzyme, and the drug which was inhibiting transglycosylase was vancomycin. So the overall drug of choice for MRSA is now vancomycin. Vancomycin is the drug of choice. But sir, the story doesn't end here. This Staph aureus now has acquired resistance against vancomycin as well. Can we call this Staph aureus as VRSA? Vancomycin resistant Staph aureus? Sir, what to give? Give a drug for VRSA, linezolid. Sir, the story doesn't end here. This Staph aureus is now becoming LRSA, that is linezolid resistant Staph aureus. For this, we give a drug streptogramin. So very good. We are fighting very strongly with MRSA, VRSA and LRSA. But sir, the story doesn't end here as well. This Staph aureus is now becoming SRSA, streptogramin resistant Staph aureus. So what are the options we are left with? We can give a drug daptomycin, a new drug. We can give tigecycline, and we can give 5th generation cephalosporins. Any drug which is a 5th generation cephalosporin, you have to identify ROL word in them. ROL means ceftaroline, ROL word is coming, and ceftabiprole. So you just have to find ROL word in them. So can we say daptomycin, tigecycline, they are effective against MRSA, LRSA, SRSA. So they are effective against all of them. Now, oral drugs for MRSA, we can remember a mnemonic C and CFTR. C, CFTR. C for we can give clindamycin. We can give cotrimoxazole, because these drugs will rather inhibit protein synthesis, they will inhibit folic acid, so they will not interfere with transpeptidase enzyme. We can give fluoroquinolones like levofloxacin, ofloxacin. We can give tetracyclines, and we can also give one anti-TB drug for tuberculosis, rifampicin. Now, which drug we have as a topical cream for MRSA? It's a very commonly asked question. Topical cream for MRSA is mupirocin cream. So, mupirocin 2% cream is a drug for MRSA. Drug of choice for MRSA is mupirocin topically. Another drug you can give is fusidic acid. But try to remember mupirocin. Now, there has been recently development of new drugs for MRSA. So, 2 new drugs we will write. These drugs are intravenous drug. One new drug for MRSA is lefamulin. And second intravenous drug is one aminoglycoside, arabic acid. So, these 2 drugs you will write just for reference, new drugs for MRSA. So, from this big list, let's now understand what question comes. The question comes is, sir, what is the overall drug of choice for MRSA? You will write the answer. The overall drug of choice for MRSA is vancomycin. It is the overall drug of choice. Now, what is the overall drug of choice for VRSA? Vancomycin resistant Staph aureus. Sir, we can give linezolid, etc. But we will not wait for linezolid. We will directly start the most effective drug, daptomycin. So, directly start daptomycin for VRSA. But there is a problem with daptomycin, that this daptomycin, it is not effective in one infection known as pneumonia. In pneumonia, it is not effective. So, if specifically question comes, VRSA pneumonia, which drug to be given? In VRSA pneumonia, give linezolid. But overall drug of choice for VRSA is daptomycin. Unfortunately, daptomycin is not available in our country. So this is about the superbug Staph aureus gram-positive. Now let's talk about gram-negative bacteria, how they have acquired resistance. So let's talk about a big gram-negative family, Enterobacteriaceae family, in which we have E. coli, Pseudomonas, Klebsiella. Now for this Enterobacteriaceae family, we made a type of penicillins known as extended spectrum penicillin. Because extended spectrum penicillins, they kill E. coli, Pseudomonas, Klebsiella, A2CT map. Now, when this extended spectrum penicillins, when they entered into this Enterobacteriaceae, this Enterobacteriaceae started producing one enzyme. In this case, the enzyme name is ESBL enzyme. And this ESBL enzyme will degrade extended spectrum penicillin. So what is the full form of ESBL? Very logical. Extended spectrum beta lactamase enzyme. So why we have name it as ESBL or extended spectrum beta lactamase enzyme? Because this enzyme will degrade extended spectrum penicillin which were used to kill Enterobacteriaceae. But the story doesn't end here. This ESBL enzyme also degrades one more group of antibiotic. It also degrades third generation cephalosporins. So third generation cephalosporins are also degraded by extended spectrum beta lactamase enzyme. Sir, now how to overcome this resistance? Sir, we have developed a class of a drug. This new class of drug is known as beta lactamase. So beta lactamase is ESBL enzyme. And let's inhibit this enzyme. We have made beta lactamase inhibitor. So these special molecules, what they will do, they will enter into Enterobacteriaceae and this molecule will block ESBL enzyme. So if this ESBL enzyme is blocked, do you think extended spectrum penicillin or cephalosporin, will they be degraded inside the bacteria? So answer is no. So this beta lactamase inhibitor molecule, they will protect these two antibiotics from degradation, that is extended spectrum penicillin and third generation cephalosporin. So logically, for ESBL producing bacteria, that is Enterobacteriaceae, we have made beta lactamase inhibitor. Beta lactamase inhibit extended spectrum beta lactamase enzyme and it is hence combined with which drug? Extended spectrum penicillin and third generation cephalosporin. So the first extended spectrum penicillin is amoxicillin. Amoxicillin is combined with one beta lactamase inhibitor, that is clavulanic acid, very famous drug. And this combination you call it as amoxicillin clavulanic acid. So now amoxicillin will not be degraded. Clavulanic acid will protect this amoxicillin from degradation from ESBL enzyme. Another drug which is combined with clavulanic acid is ticarcidin. Next we have extended spectrum penicillin, ampicillin. Ampicillin, it is combined with one molecule, beta lactamase inhibitor, that is sulbactam. And we have another extended spectrum penicillin, piperacillin. And this piperacillin, it is combined with tazobactam. Very famous combination. Sometimes we commonly call it as piptaz. Piptaz means piperacillin and tazobactam. Yes, there are certain third generation cephalosporins which are combined. These are just for the reference we will write. So their combination is very important. So one question comes in our mind. Sir, these molecules which are beta lactamase inhibitor, which are protecting these penicillin and cephalosporin, can they kill this bacteria on their own? The logical part is no. These molecules cannot itself kill bacteria. They are just inhibiting or blocking the enzyme which are degrading penicillin and cephalosporin. But there is an exception to this rule. Exception is sulbactam. Sulbactam can itself kill a bacteria. It can kill one bacteria known as Acinetobacter baumannii. So sulbactam has antibacterial activity against Acinetobacter baumannii. Now sir, the story doesn't end here. These ESBL producing Enterobacteriaceae, now they are becoming even resistant to these beta lactamase inhibitor. So let's see now what is the cause of resistance. So let's talk about Enterobacteriaceae, which contains E. coli, Pseudomonas and Klebsiella. The first enzyme they started making was ESBL enzyme. Remember, ESBL enzyme, It is a plasmid encoded enzyme. So there is a small chromosome in a bacteria apart from big chromosome. It is plasmid. And this ESBL we know degrades extended spectrum penicillin, and it also degrades third generation cephalosporin. So what is the treatment? With this extended spectrum penicillin and third generation cephalosporin, we started combining beta lactamase inhibitor. Beta lactamase inhibitor, because this beta lactamase inhibitor will inhibit ESBL enzyme. Now, sir, the story doesn't end here. This Enterobacteriaceae is now even becoming resistant to these beta lactamase inhibitors as well. So in that case, we can give fourth generation cephalosporins. Fourth generation cephalosporins, they are resistant to ESBL enzyme degradation. Third generation are degraded, fourth generation are not degraded. Sir, even we can give next group, that is carbapenem group. Carbapenem group of antibiotic is also resistant to ESBL enzyme. So any drug in carbapenem, it will end with the word penem, like imipenem, like meropenem, etc. So imipenem and meropenem, they are resistant to ESBL enzyme. They are overall considered to be the drug of choice for ESBL producing Enterobacteriaceae like E. coli, Klebsiella and Pseudomonas. But sir, story doesn't end here. These E. coli, Pseudomonas and Klebsiella, now they have started producing another enzyme. And this enzyme is mainly produced by big chromosome. Big chromosome of this bacteria has started producing an enzyme. And let's call this enzyme as carbapenemase. Carbapenemase enzyme it has started producing. That means it will now degrade carbapenems. It will now degrade carbapenems as well. Don't you think it's a big problem? And this carbapenemase enzyme, it is also known as metallo-beta-lactamase enzyme. So what to do now? If it is becoming resistant to carbapenem, we can start a drug known as colistin. Colistin is overall the drug of choice for carbapenemase producing E. coli, Klebsiella, etc. And one strain of this bacteria was found in the capital of India, Delhi. And we called this E. coli strain or Klebsiella strain, which was resistant to carbapenem. That bacteria was known as Delhi superbug. What is this Delhi superbug? Delhi superbug is carbapenemase producing Enterobacteriaceae, and it was resistant to carbapenems as well. It was found in Delhi, AIIMS Hospital and Sir Gangaram Hospital. So we named this bacteria as Delhi superbug. In Delhi superbug, give a drug colistin in carbapenem resistant cases. But we fought back. We fought back with this bacteria and we have made new special molecules. These new special molecules will inhibit now carbapenemase enzyme so that carbapenems are not degraded. Hence, we made new beta-lactamase inhibitor. This new beta-lactamase inhibitor will now inhibit carbapenemase enzyme. So, don't you think they will protect carbapenems now? So, the first carbapenem is meropenem. This meropenem, it is combined with vaborbactam. New drug. Imipenem, another carbapenem, it is combined with relebactam. So can we say combination of meropenem with vaborbactam and imipenem with ralibactam, which are new beta-lactamase inhibitor, which inhibit carbapenemase enzyme. They are given for carbapenem resistant cases of bacteria like Delhi superbug. Similarly, we have one more drug which can inhibit carbapenemase enzyme. The drug name is avibactam. And this avibactam, it is combined with ceftazidime. And these drugs are given for carbapenem resistant bacteria. So in nutshell, now let's make a summary of all the beta-lactamase inhibitor we have. So these beta-lactamase inhibitor, they will protect the other drug. With amoxicillin and ticarcillin, we were combining clavulanic acid. With ampicillin and cefoperazone, we were combining sulbactam. With piperacillin, we were combining tazobactam. And two cephalosporin names we have already written, cefoperazone and ceftolozane. So this combination is given for the treatment of ESBL, extended spectrum beta-lactamase producing Enterobacteriaceae like E. coli, Klebsiella and Pseudomonas. But now we have made other beta-lactamase inhibitor, avibactam. Avibactam, it is combined with ceftazidime, meropenem, vaborbactam, and imipenem, it is combined with ralibactam. And this combination is given for the treatment of carbapenemase, another enzyme which were degrading carbapenem, producing Enterobacteriaceae. So this is how we overcome resistance to any bacteria. So this is a very ongoing fight which will never end. The bacteria will try to find new ways of resistance, and so we human will find new ways of overcoming this resistance. So let's make a summary now. Beta-lactams like penicillin, cephalosporin, vancomycin, bacitracin, fosfomycin. All these drugs are cell wall synthesis inhibitor. So they all are cell wall synthesis inhibitor. Penicillin, cephalosporin and carbapenem, they inhibit cell wall by inhibiting transpeptidase enzyme. All above drugs are not effective in atypical bacteria. So atypical bacteria like Mycoplasma, Chlamydia and Rickettsia, these drugs are not effective because these atypical bacteria, they lack cell wall. So what was the drug of choice for rat bite fever, tetanus and gas gangrene during the time of World War? We discussed penicillin G. Let's give this respect. G was a drug of choice. So probenecid was combined with penicillin to make penicillin longer acting, so that penicillin G is not excreted out in urine. So what was the drug of choice for prevention or prophylaxis of rheumatic fever? The longest acting penicillin for prophylaxis was benzathine penicillin. And this benzathine penicillin was given in all stages of syphilis, except which stage? Except neurosyphilis, we don't give benzathine penicillin. So the drug of choice for neurosyphilis was rather aqueous penicillin. So aqueous penicillin was either penicillin G or procaine penicillin. So penicillin hypersensitivity, if seen in syphilis, it was called as Zarisch-Herxheimer reaction. So it's a name of a scientist. Now extended spectrum penicillin, why we made like A2CTMAP, ampicillin, amoxicillin, piperacillin? Because they were effective against Enterobacteriaceae family like E. coli, Pseudomonas, Klebsiella. So what was the drug of choice for Listeria infection? And enterococcal infection, Listeria causes meningitis, Enterococcus causes endocarditis. We give ampicillin, and this ampicillin was combined with gentamicin. Now, what was the drug of choice for Streptococcus pneumoniae, all ENT infection? It was amoxicillin. Next question, cloxacillin, dicloxacillin, oxacillin and methicillin, condom. These penicillins were given for penicillinase producing Staph aureus. Because this Staph aureus was degrading penicillin G, they were penicillinase resistant penicillin. But what was the drug of choice for MRSA? Methicillin resistant Staphylococcus aureus. The overall drug of choice is vancomycin. Now, which beta-lactamase enzyme inhibitor is combined with amoxicillin and ticarcillin? We combine clavulinic acid. That is why this combination is amoxiclav. Which beta-lactamase inhibitor is combined with ampicillin? Very commonly asked question. Sulbactam. And which beta-lactamase inhibitor was combined with piperacillin? It was tazobactam. This combination comes with a brand name, Piptaz. So now let's solve certain MCQs. So which of the following rationale is for combining penicillin G with probenecid? We discussed probenecid inhibit OATP transporter and inhibits urinary excretion of penicillin G. That is why it makes penicillin G longer acting. So can you tell me what is the best option? So best option is D. It renal tubular secretion of penicillin into the urine is inhibited by probenecid. Next question. What is the treatment of choice in a patient of tertiary syphilis? Remember, we gave benzathine penicillin. So benzathine penicillin, we gave 3 injections of 2.4 million international unit. So the total dose will become 7.2 million international unit because we gave 3 injections. Next question, which drug to be given in the treatment of which infection? So first is vancomycin. Remember, vancomycin is given for treatment of MRSA, drug of choice. Ampicillin, it is given for the treatment of choice for Listeria meningitis. Then we have piperacillin. Piperacillin was effective in Pseudomonas, and penicillin G, it was given for tetanus as a drug of choice. Next question, which of the following drug is not effective in MRSA? Remember, in MRSA, there is mutation in transpeptidase enzyme. And all beta-lactams, they act on transpeptidase enzyme. And there were 4 drugs in beta-lactam: penicillin, cephalosporin, carbapenem, and monobactam. So can you identify which of the following drug is a penicillin? Any drug that ends with the word cillin is a penicillin. Penicillins are not effective against any penicillin, not effective against MRSA. So we discussed mupirocin is a topical drug for MRSA. Rifampicin was an oral drug for MRSA. And vancomycin was an IV drug for MRSA, which is overall considered to be the drug of choice for MRSA. And this finishes our cell wall synthesis inhibitor part 1. Best wishes. Thank you very much.